Hello everyone, this is Christopher Bear. I'm a registered nurse, a respiratory therapist, and an advanced emergency medical technician. And I'm a full-time faculty member of the Doñana Community College. And what I'm going to be talking about today is a review of the pathophysiological basis of a cellular hypoperfusion. So basically what I'm going to be talking about today is shock. I just want to go ahead and go over a quick caveat. This is a presentation on the contemporary ideas and evidence regarding shock and trauma management. Some of the material that I'm going to be talking about may run contrary to your current protocols, and I'm in no way suggesting that you defy your protocols. However, I do think that frank, honest, and evidence-based discussion with your medical director about newer evidence and guidelines may be helpful for your service to develop protocols and practice guidelines that take into account this newer evidence. And clearly, you may actually be utilizing modalities and methodologies that are reflecting the new evidence. So this is just kind of a general caveat that I want to throw in there whenever we start talking about doing things a little differently than we have traditionally. Okay, just quickly to review the objectives. The objectives for this discussion are going to be develop a rudimentary understanding of the aerobic process of cellular respiration, develop a rudimentary understanding of the pathology of sustained anaerobic cellular respiration, develop a rudimentary understanding of the mechanisms behind adequate perfusion and cardiac output, and finally appreciate the contemporary modalities for managing hypovolemic shock caused primarily by hemorrhage. So this is going to be a discussion that is going to focus more on hypovolemic shock, specifically hemorrhagic shock, and so this will be a trauma-related lecture, and of course this should show up in your trauma module. So let's just go ahead and briefly review the components of cellular respiration just to make sure everyone's on the same page. So cellular respiration is simply the process of cellular energy production. There are two different but certainly complementary pathways that occur. There is what's known as the anaerobic pathway. This does not involve oxygen. And whenever I say oxygen in this discussion, you should just assume that I am talking about the diatomic gas molecule of oxygen. When dealing in chemistry, when we talk about elemental oxygen, that is a single oxygen atom by itself. However, in the context of this discussion, oxygen will mean a diatomic molecule, that is, two atoms of oxygen that are covalently bound together to create the O2 molecule. So the anaerobic pathway does not involve oxygen, and the aerobic pathway involves oxygen. And I think sometimes there is this way of thinking about energy production that one pathway or the other is kind of on or off. So a lot of people, some people tend to think that if the aerobic pathway is working, then the anaerobic pathway is turned off. Or if I am in a situation where I'm in a shock situation or being hypoperfused, aerobic respiration is turned off and then anaerobic's turned on. That's not the case. In fact, as we'll talk about a little bit later on, both pathways are working simultaneously, and you actually need both pathways to work together, and therefore we call them complementary. A limited energy production is possible with anaerobic respiration, but it's not enough to power, quote unquote, most cells within our body. Certainly other cells, like bacteria, for example, some of them can use anaerobic respiration to produce and meet their energy needs. That is not the case with the type of cells in the human body known as eukaryotic cells. So this is just a quick bit of useless trivia you can use to amuse and bemuse your friends. And this is a question: what is the only cell in the human body that can meet its energy needs using only anaerobic pathways? And it's actually a very common cell, and it is a red blood cell. The red blood cell does not need oxygen to make energy. It uses only anaerobic energy production pathways, and that's probably a good thing because, as we know, red blood cells transport oxygen, and we certainly don't want to be in a situation where our red blood cells are using the oxygen that they're containing, and that oxygen isn't getting to the tissues and the cells of our body. Okay, so let's just look at cellular respiration in a little more detail. I like chemistry quite a bit, so if we look at the general chemical formula for energy production, if we start on the left, we start off with C6, that's 6 carbon atoms, 12 hydrogen, H12O6, 6 oxygen atoms, and that is the chemical formula for glucose. Glucose is C6H12O6. The little s just means it's a solid. So basically in the cell I have glucose plus 6 molecules of O2 in its gaseous form, and the little arrow means that there's a bunch of chemical reactions that occur, and that yields waste products of 6 carbon dioxide molecules in its gaseous form, plus 6 water molecules, and obviously that's a liquid, plus a lot of heat being released. Well, that's pretty interesting. However, the real story is a bit more detailed, and in the end it involves production of our good friend, the adenosine triphosphate, or ATP molecule. So it's all about the ATP. And the way that I think of ATP, because we often learn that ATP is the molecule, it's the energy molecule within our cell, but how exactly is it an energy molecule? Well, if you look at adenosine triphosphate, it's an adenosine molecule with 3 phosphate PO4 groups attached on the end of it. And basically what happens is that last phosphate group can kind of, if you think of the molecules kind of like a gun and you pull the trigger of that gun, that last phosphate group kind of flies off. It can shoot off. That's a crude way of looking at it. And the energy that is released by that shooting off is what is used to power different cellular processes. Okay, so let's get into the nuts and bolts of energy production. There's a whole bunch of stuff up here, and we're not going to go through every intermediate molecule. We're just going to focus on the major pathways. So there are 3 major pathways to producing energy. And I want you to kind of imagine that this picture here, all of this stuff is surrounded by a cell. And right at the cell membrane, as glucose comes into the cell, we have our first pathway, and this is known as glycolysis. Glucose comes in, and pyruvate, so you can see glucose at the top there, and through several steps, that glucose is transformed into what's known as pyruvate or pyruvic acid. Now you can see that I have some ATP produced. I actually have 4 molecules of ATP produced here, but 2 molecules are used just to run glycolysis, and I'm only making 2 molecules of ATP per pass through glycolysis. And interestingly enough, glycolysis is the anaerobic pathway of energy production. So you can see that it doesn't make a whole lot of energy, and it produces a lot of pyruvate. Okay, so that's the first thing that happens when glucose comes into the cell. Glucose, through anaerobic metabolism, is transformed into pyruvate. That pyruvate is then turned into acetyl-CoA, or acetyl coenzyme A, and it is fed into the second pathway. And the second pathway lives within an organelle known as the mitochondria. And you guys remember the mitochondria is the powerhouse, the energy factory of the cell. And in the Krebs cycle, the acetyl coenzyme A basically has lots of carbons on it. And what happens is various enzymes and chemical reactions tear hydrogen off of those carbons. So basically I have a carbon skeleton with a bunch of hydrogens, and I'm tearing all those hydrogens off. And as those hydrogen atoms are being torn off, you can see these little NAD and FAD molecules grab those hydrogens, and NAD becomes NAD+, and then FAD becomes FADH2. So they're in the Krebs cycle, we're tearing hydrogens off, and NAD and FAD are kind of gobbling those hydrogens up. And then what's left behind in the Krebs cycle? Well, I have a bunch of carbon and a bunch of oxygen from the original glucose molecule, and of course that carbon and that oxygen produces CO2. So this is actually where all of the carbon dioxide waste is produced in our body, in the Krebs cycle, and it's produced by breaking acetyl coenzyme A down. And then finally we move into the third pathway, which actually is within the membrane of the mitochondria, right here. And this is known as the electron transport chain. What happens in the electron transport chain is the NAD and the FAD dumps all that hydrogen off, and the hydrogen is up on the top there, and I tear an electron off the hydrogen, and the electron travels through, and you can see those four little cylinders that go through the membrane. Those are known as cytochromes, and they're proteins or enzymes that do stuff. And those electrons are used to power those cytochromes. And then at the very end, the fifth little thing that looks a little different from those other four, that is known as ATP synthase. And what that is that is actually where most of the ATP in our body is produced. And basically what happens is I have hydrogen, a very concentrated gradient of hydrogen on one side of the membrane, no little hydrogen on the other side of the membrane, so the hydrogen wants to travel through that ATP synthase channel because I have a gradient. As the hydrogen travels through that channel, it turns that channel around and allows that channel to attach phosphate group to ADP, and ADP then becomes ATP, and that is known as proton motive force. So that is how we produce our ATP. But now I have a lot of garbage left over. I have lots of hydrogen ions coming through that channel and lots of electrons. And I need some way of getting rid of all that garbage. And so you can see the fourth cytochrome there, next to the very last, next to ATP synthase. That cytochrome is known as cytochrome C oxidase. And this is where oxygen comes into play. Oxygen works at cytochrome C oxidase to attach to the hydrogens and the electrons and to get rid of all that stuff. And that chemical reaction produces H2O or water molecules. So this is the true aerobic pathway, the electron transport chain. This is where we need oxygen, and oxygen is basically an intracellular garbage truck getting rid of all of those hydrogen ions and electrons. And collectively, these three pathways produce all the energy within our cells. So let's just talk about anaerobic metabolism. In anaerobic metabolism, in the human body at least, I have a state of hypoperfusion where I can't get oxygen. If I can't get oxygen to the electron transport chain, it shuts down. Well, then what happens? Well, if it shuts down, then stuff starts backing up into the Krebs cycle, and the Krebs cycle eventually shuts down. And what does that leave us with? Well, that leaves us with a bunch of pyruvate piling up from glycolysis. And I can't do anything with that pyruvate, right? I can't feed it into the Krebs cycle, so it piles up. I'm not making a whole lot of ATP, and the pyruvate breaks down into lactic acid. And this is where we can develop our lactic acidosis of shock, because the electron transport chain and Krebs cycle have shut down due to the lack of oxygen. The only cycle that is running is glycolysis. Okay, so cellular schema and acidosis. So, to take home points here, when cellular perfusion is compromised, anaerobic metabolism ensues. Some cells, however, are good at dealing with ischemia, such as skeletal muscle. Skeletal muscle can be ischemic. It can be hypoperfused for an hour or two and do okay. Other cells, however, such as neurons, cannot tolerate significant ischemia for more than a few minutes. So what's the bottom line? Well, adequate perfusion of tissues and cells come down to two basic concepts. I need adequate cardiac output. My heart needs to put out adequate amounts of blood. It needs to pump adequate amounts of blood to those cells to keep them in aerobic metabolism. In addition to that, the blood that's actually being pumped out of the heart, it has to have hemoglobin, and it has to have adequate amounts of saturated hemoglobin. If I just had water coming out of my heart, well, I may have adequate cardiac output, but if I don't have the hemoglobin and I don't have the ability to transport oxygen to the tissues, then that cardiac output is meaningless. Likewise, I can have all the hemoglobin in the world, but if I don't have good cardiac output, I can't get that hemoglobin to the cells. So, shock is not a number, and we often like to kind of shoehorn shock into a number and say, oh, it's a blood pressure less than this, or it's a saturation less than that. Shock is not a number. It is not a single sign or symptom, but rather it's a constellation of findings. When you think somebody's in shock, it's a constellation of signs and symptoms that indicate cellular hypoperfusion. Okay, so let's go ahead and talk about the two components. We'll talk about cardiac output first, and you guys probably remember this formula from paramedic school. And the formula is cardiac output equals heart rate times stroke volume. So if somebody has a heart rate of, let's say, 100, okay, so 100 beats per minute, and let's just say that they have a stroke volume of, let's just do something that'll make the math easy, 50 milliliters. Okay, so what I do is I take 100 multiplied by 50, and that gives me 5,000 milliliters, or 5 liters per minute. So that's how I calculate the cardiac output, but let's look into this a little deeper. So there are two things that go into cardiac output: my heart rate and my stroke volume. Okay, how fast my heart is beating and how effectively or efficiently my heart is beating. So let's talk about the two things that determine heart rate. These primarily revolve around sympathetic and parasympathetic tone. Sympathetic tone tends to increase. If I have increased sympathetic tone, my heart rate increases. If I have increased parasympathetic tone, my heart rate decreases. And likewise, if I block the sympathetic nervous system, my heart rate will decrease, or if I block the parasympathetic nervous system, my heart rate will increase. Now let's talk about the three things that go into stroke volume. They include preload, afterload, and contractility. Okay? So let's look at these in a little more depth. So let's first talk about things that can affect heart rate. Neurogenic and spinal shock. Okay, if I have a spinal shock and I have a spine injury of my thoracic region or above, we know that a lot of the sympathetic nerves come out of the thoracic region, and if I have that kind of spinal injury, a high thoracic or above spinal injury with compromise of the cord, I in essence cut the sympathetic nervous system off. What does that leave me with? Well, that leaves me with only parasympathetic tone, and clearly that's going to decrease my heart rate. And obviously, certain drug toxicities are going to lead to a decrease or increase in heart rate, depending on the toxicity or the toxidrome that we're dealing with. Okay, let's talk about stroke volume now. So things that affect preload. Well, preload is the amount of blood coming into the heart. Okay, it is the amount of blood that comes into the heart, it's the amount of blood that we can preload into the ventricles. Things that decrease preload: hypovolemic shock. If my volume is low, clearly I have low volume in my circulatory system. That's going to equate to low volume going into the heart. Obstructive shock. If I have a pneumothorax, if I have a tension pneumothorax, or I have cardiac tamponade, that is going to obstruct the flow of blood into the heart. And of course, if blood flow can't get into the heart, then the heart isn't going to have anything to pump. A redistributive shock. This can include anaphylactic and septic shock. Again, if I have massive vasodilation, which occurs in septic and anaphylactic shock, I basically produce a relative hypovolemia, right? My container gets bigger, and now I don't have enough fluid to pump around, and we're right back up there into the hypovolemic category. And then, of course, certain toxicities, certain drugs can cause massive vasodilation and things like that that decrease the preload. Afterload is the amount of pressure, amount of force that the left ventricle has to overcome to get fluid out into the body. So clearly, if someone is fluid overloaded, they have excessive vasoconstriction, or maybe they have a hypertensive urgency or crisis, that heart is going to have to work much harder to get blood out, and that could compromise the amount of the volume getting out of the left ventricle. And then we move to contractility, and this is the inability for the ventricle to function properly, and generally this is a result of cardiogenic issues: cardiogenic shock or congestive heart failure, certain toxicities, which are certain drugs which are toxic to the myocardium, and then even neurogenic and spinal shock can depress the contractility of the heart. So we have lots of different things that go into cardiac output. Okay, now let's change direction here and talk a little bit about oxygen transport and delivery. And the way that we calculate the ability for the body to adequately transport oxygen is something known as the C(a)O2. Whenever you see a little a, and you're talking about oxygenation, a little a means arterial. So we're talking about the content of arterial oxygen. A big A would be actually alveoli, and there is actually something called a PaO2, which is a pressure of the alveolar oxygen. But this is the C(a), so this is arterial. The formula for calculating CaO2, and I'd probably write this formula down because you may actually have to use it for your homework, is taking the hemoglobin level in grams per deciliter, or grams per 100 milliliters, whatever that value may be. And as you remember, the normal value is approximately 15 grams per deciliter in the average adult, a little higher in men, a little lower in women, times the arterial saturation, the SaO2, not the SpO2. SpO2 is pulse oximetry. SaO2 is a saturation of arterial oxygen. This is something that we would need to get off of a blood gas. You take your hemoglobin level times your arterial saturation multiplied by 1.34. 1.34 is what we call a coefficient or a constant. Basically what that means is every gram of fully saturated hemoglobin can hold 1.34 milliliters of oxygen. Okay, so hemoglobin times SaO2 times 1.34. And then whatever that number is, you write it down. And then you have to do another calculation. You have to take the PaO2, that's arterial oxygen, multiply that by 0.003, and whatever number you get there, you add to the first number. So you can see that the most important factor here is adequate amounts of well-oxygenated hemoglobin. Your PaO2 could actually be low, and as long as you had adequate amount of well-saturated hemoglobin, you're going to be able to adequately transport oxygen. And we often see this in COPD patients who may have low PaO2s, but they have a polycythemia, they have more hemoglobin than normal, and they're able to effectively transport oxygen even though their PaO2 is low. The PaO2 actually matters very little in transport oxygen. So the answer we get is in milliliters per deciliter, or what we call vol percent. The normal value is approximately 15 to 20 vol percent in an adult. And let's just kind of work through one real quick. So let's say that I have a patient here. A patient has a hemoglobin of 15, an SaO2 of 100%, and a PaO2 of 100. Now what I need to do is I need to convert that percent into a fraction. So 100% is just 1. 80% would be 0.8, 70, 0.7, and so on. So I plug that in. My hemoglobin 15 times 1. Okay. So I go 15 times 1. And then I need to multiply that by 1.34, and that gives me a value of about 20%, 20. And you can see here somebody who did the math there, they came up with 15.3, but they forgot to multiply by the 1.34. So that 1.34 makes a big difference. So it's 15 times 1, which is just 15, okay, and then 15 times 1.34 gives us 20.1, and then I take 100 multiplied by 0.003 gives me 0.3, and then I add, and that is about less than 20.5, so we'll just say that's 20. So this person would have an SaO2 of 20 vol percent, which is in the normal range. Okay. Let's talk now about the hemoglobin's ability to transport oxygen, and this is represented through something called the oxyhemoglobin dissociation curve. If you look at this picture here, this picture plots the oxyhemoglobin saturation, the SaO2, to the PaO2, okay? And that big blue line in the middle is the normal relationship between oxygen saturation and the PaO2. Now, that is what we call the normal affinity. If I have hemoglobin, however, that has what we call a right-shifted hemoglobin, and that's that red dotted line there, anything to the right, what that means is the hemoglobin has a decreased affinity for oxygen. So a right shift is a decreased affinity for oxygen. And that means that the hemoglobin, a right shift means the hemoglobin likes to release oxygen. Things that cause a right shift, the things that are important for us here are the decreased pH and an increased temperature. Okay, so if my patient's pH decreases, they become acidotic. Their hemoglobin is going to want to release oxygen. And this is, when this happens at the cells, this is known as the Bohr effect. This is generally a good thing when this happens at the cells, because the cells, obviously, as blood's going around the cells, the pH is going to be a little lower because there's carbon dioxide there, okay? And that's going to prompt the red blood cells to release oxygen to the tissues that need oxygen. That's pretty easy, that's good. We can run into problems, however, when our patients are acidotic all around their body, and now they have oxygen or they now have hemoglobin that just doesn't want to hold on to oxygen, period. And if that's the case, if it's releasing all of its oxygen, it may not be able to adequately transport it to where it needs to go. Likewise, we can also have something called a left shift, and a left shift is a situation where hemoglobin really likes oxygen. It's called locking. I think of it, a left shift is the green line, hemoglobin is locking on to oxygen. The relevant things that will cause a left shift in our hemoglobin is an increase in the pH, so alkalosis, and a decrease in the temperature. Okay, so if somebody becomes highly alkalotic, their hemoglobin will lock onto oxygen and it won't let oxygen go. And sometimes we can run into this, particularly in the pre-hospital environment. If I have, let's say, somebody who has a head injury and I'm bagging them and things aren't going well, we have a tendency to hyperventilate patients. And if we hyperventilate them too much and their pH, we blow off too much CO2 and they become very alkalotic, we are going to change the hemoglobin within that person, and that hemoglobin will not want to release oxygen. It is left-shifted hemoglobin. It will not release oxygen to those cells. Even though your patient's pulse oximetry may be 100%, that hemoglobin will be very reluctant to release its oxygen to the cells. So in either case, too high of a pH or too low of a pH, you can run into hemoglobin that does not have a normal relationship with oxygen, and that can cause problems with getting oxygen to those cells. Okay, so let's focus in on hypovolemic shock, since that's really what I wanted to talk about as it relates to shock. So hemorrhage impacts both processes. It impacts both the ability to transport oxygen, because I'm actually losing blood, and it impacts decreases preload, right? There's less blood coming to the heart. So hypovolemic shock causes problems on both fronts. Contemporary treatment has actually changed quite a bit, and it revolves mainly around aggressively controlling hemorrhage and rapid transport to definitive care. Now, there is a lot of discussion about IV fluid resuscitation, okay? In the last 10 years, the paradigm has changed fairly significantly. When we got in, say 10, 15, even longer than that, years ago, you may have been in a situation where you were administering large amounts of fluid. And some of you may, if you're old enough, you may remember the 1-to-3 formula. And that is, for every milliliter of blood lost, you need to give at least 3 milliliters of lactated Ringer's or normal saline solution. So if somebody lost 1 liter of blood, you'd need to give them at least 3 liters of crystalloid, isotonic crystalloid in the field. Some people even advocated 1 to 8 isotonic crystalloid volume resuscitation. Okay, so IV fluid resuscitation modalities are numerous right now. and the evidence is not perfectly clear on where the best therapy lies. Okay? Many modalities, however, are starting to center around a principle broadly known as permissive hypotension. And in permissive hypotension, what we do is we limit the amount of fluid we give in the pre-hospital environment, and we attempt to maintain somewhat of an adequate mean arterial pressure. And we like to have radial pulses present. The magic number, we don't have a magic number. A lot of people say, well, if I can keep the systolic pressure around 90 or so, and maybe keep my mean arterial pressure, around 50 or 60 or so, I'm going to be doing okay. These are just rough numbers, and the evidence, there's just a lot of evidence out there, and some of it contradicts. It's kind of a blurry area. We do know that exceptions do exist, and that commonly occurs in the case of a head injury. We know that if I allow a person with a head injury, if I allow that person to become hypotensive, I have increased their risk for morbidity and mortality substantially. So generally, people are still doing fairly aggressive resuscitation if a head injury exists because they want a little higher blood pressure. New evidence from the battlefield, however, does not support the aggressive use of fluids. Okay? The contemporary thinking is as follows. That aggressive fluid resuscitation leads to a couple of problems. First of all, it leads to what's known as hemodilution. I've lost blood, and now I'm giving lots of fluid, a crystalloid that can't transport oxygen very efficiently, and I'm diluting out my ability. I'm diluting out that hemoglobin. I'm diluting out those red blood cells, and I'm actually diluting the ability for what blood I have to transport oxygen. In addition to that, I'm increasing the blood pressure, and I may actually blow out clots and increase the bleeding, and I may be altering the ability for the blood itself to clot, to form new clots. And this is something known as a coagulopathy, where I have a clotting disorder. So there are three problems that we think we may get into if we're aggressive with fluids. Some experts even recommend judicious administration of hypertonic saline. There's some research on 3%, even 7.5% hypertonic saline solutions. There also is evidence based around colloid solutions. Colloids, of course, are very large molecules, carbohydrate-like molecules, sometimes proteins. The big one that we see in the battlefield right now is a combination of hetastarch and lactated ringers, and this is known as Hextend. We don't typically see Hextend in the United States outside of the battlefield, but we do see a medication called Hespan, which is the hetastarch molecule without the lactated ringers. Okay, so regardless of the controversies that we have surrounding fluid resuscitation right now, everyone can agree on one thing: hemorrhage control is priority. Aggressive control of external hemorrhage must occur, and it must occur as early as possible. The use of tourniquets are an important, if not critical, component of hemorrhage control, and data from the battlefield currently contradicts the traditional paradigm. The traditional thinking that says if I apply tourniquets, I'm going to make clots, and I'm going to increase the risk of pulmonary emboli, I'm going to increase the risk of nerve damage, I'm going to increase the risk of an amputated limb, and I'm going to increase the risk of compartment syndrome. All of the evidence coming out of the battlefield, for the most part, contradicts that paradigm. And in fact, we now find that the problems associated with tourniquet use are very low. There's a very low complication rate. And limb amputations and all that are not necessarily due to the tourniquet being applied. They're due to the underlying injury itself. Tourniquets have become so important, they are now included in the pre-hospital trauma life support literature, and they are an integral component of the National Registry Emergency Medical Technician Psychomotor Skill Station for bleeding and shock management. This is a skill station that a lot of the new EMTs, advanced EMTs, and paramedics will have to negotiate through, and they will have to more than likely apply a tourniquet to successfully negotiate that station. So clearly, tourniquets have become popular, and the evidence does support that using a tourniquet is a positive thing if direct pressure fails to control hemorrhage. Okay, in addition to that, we do know 3 distinct problems cause increased morbidity and mortality in trauma patients. So important are these 3 things that we actually have come to call them the trauma triad of death. And they include the 3 following things: acidosis, hypothermia, and coagulopathy. If my patient becomes acidotic, acidosis changes the way proteins work. Acidosis can also change the way clotting works. And as we talked about earlier, acidosis fundamentally changes the way hemoglobin works because hemoglobin is a protein. And proteins have what's known as conformation. Conformation is a special shape that allows a protein to do what it does. And acidosis can change the conformation of proteins and make them work differently or not allow them to work at all. Hypothermia. There tends to be a way of thinking that says hypothermia is a good thing because it slows things down and it somehow preserves the brain. What we find in trauma is if my patient becomes hypothermic, their ability to clot decreases substantially. We found this out painfully in Iraq and Afghanistan. And there were lots of patients, in spite of the hot conditions, were being loaded up into helicopters, flown around, wind blowing over them. They're already in shock. They already can't thermoregulate, and they become hypothermic, and they bleed much more. And of course, both acidosis and hypothermia lead to the development of coagulopathies or clotting disorders. Okay, so it is going to be critically important for us as pre-hospital providers to prevent our trauma patient from becoming hypothermic. Okay, hypothermia is an important component of post-resuscitation care for medical arrest, a VFib, VTAC arrest that doesn't regain consciousness immediately following ROSC. Hypothermia, however, is a devastating problem in the trauma patient experiencing or suspected of experiencing hypovolemic shock. Okay, guys, in summary, shock is hypoperfusion at the cell level. Sustained shock causes conversion to anaerobic energy production. Basically, it stops the aerobic pathways, and the only pathway that continues to work is the anaerobic pathway. This results in a markedly decreased in ATP production and the production of lactic acid along with other harmful intracellular changes. Perfusion depends on 2 things: adequate cardiac output and amounts of well-saturated, normally functioning hemoglobin. We know hemorrhage control is a critical component of trauma care in the field, and tourniquet use is an important part of controlling external hemorrhage when direct pressure fails. IV resuscitation strategies are rather controversial, but overall data suggests that large volume crystalloid resuscitation is probably not effective and possibly harmful in some cases. And then finally, recognizing that components of the trauma triad of death increase morbidity and mortality, it is important to recognize this, and it is important to take measures to control these issues, such as preventing hypothermia. Okay, guys, I'm just going to go ahead and leave you with the references. I used Wikipedia Commons for the photographs, so there shouldn't be any copyright issues. You can reference the Pre-Hospital Trauma Life Support 7th edition textbook for additional information. And you can also go on the internet and look up Dr. Jeffrey Guy. He actually is one of the major authors for the PHTLS textbook. In addition, he does a series of podcasts on PHTLS pharmacology, and he does a great podcast series known as Surgical ICU Rounds. They're free download, and you certainly he covers all of the contemporary evidence in a fair amount of detail, and is a very good source if you are interested in studying this subject further. Okay, guys, I hope you enjoyed this. I hope you got something out of this, and hopefully this is something new, interesting, and ultimately relevant for your practice. Take care, and we'll see you all in December.